syndrome with the B mutation via MRI, which 2013 seems like eons ago, and the fact that she was capable to do that across the ocean was amazing. She has partnered with Dr. Vandernap, and they have been really pioneering the 4-H syndrome and continuing to learn new things about the syndrome to pass on to families. Dr. Wolf.
Thank you so much, Tammy, Christina, and Ron, for hosting this evening and for inviting me to share some of our experiences. I'm really glad seeing so many participants, so thank you for joining this afternoon or this evening. And please do ask your questions also when I'm showing the slides. You don't have to wait until the end because I think it's not such a huge group, and it will be much nicer when we can discuss your points directly. So I will try to share my screen. Could you give me screen sharing rights? Oh, I think I see it there. Okay. Yes, now you should see it as well. So I think there are no conflicts of interest with funding and consultancies. So I have the huge privilege and also pleasure to work in the Amsterdam Leukodystrophy Center. It's dedicated to translational research on leukodystrophies, and Professor Mario van der Knaap, some of you may have heard from her, is the head of the center and founded it more than 20 years ago. And we work from disease models to study pathomechanisms to treatment trials. Actually, this year we will start 2 investigator-initiated treatment trials for leukodystrophies in our center. We have an international reach, so we receive MRIs and also patients from all over the world. We have strong collaborations in the Amsterdam University Hospital and fortunately also strong international collaborations. We cooperate with patient associations because that's indispensable with rare diseases. So I'm really glad that the Yaya Foundation works for H syndrome. And recently we started also collaborations with pharmaceutical industry to push forward treatment trials. And what do we do? How do we work? We work on MRI analysis. We have defined several new leukodystrophies and also identified the causal genes. We do natural history studies and have set up several disease registries. We also learn a lot from tissue studies, brain tissue actually donated by patients. We have a pathologist dedicated to leukodystrophy research. We try to understand disease mechanisms, improve and develop treatments, and also, as I mentioned, we will start the treatment trials later this year. And this is, of course, also for me, a very rewarding time that we are able to diagnose our patients, but also starting to treat them. So as for H leukodystrophy is an ultra-rare disease, collaboration is the key. And it's a worldwide collaboration, and you mentioned already Geneviève Bernard and Adeline van der Ver, who are the closest collaborators on 4-H leukodystrophy. And collaboration not only with researchers, but also with families is essential to better understand those super rare disorders. So a bit about the history of 4-H syndrome, on how it's called nowadays 4-H leukodystrophy. I saw my first 4-H patient in 2000, so that's more than 20 years ago, and I was a junior doctor in my second year of internship for pediatrics. and I saw that a little girl, and she was 8 at that time. She had just had a severe varicella infection and chickenpox infection, and had deteriorated quite a lot thereafter. She had this very peculiar teeth. She didn't have many teeth, only some molar teeth, otherwise no teeth at all. And 2 years later, I saw another girl. She was 4 years at that time, and she had actually the same MRI and the same tooth problems. She had a little bit more teeth, but otherwise it was the same. So I thought, is that something common? Is this one disease? I couldn't find in the literature anything comparable. There was one family with white matter abnormalities, but no hypomyelination and lacking teeth, but those were related patients from siblings from one family. So nothing which told me this has been seen or recognized before. So together with colleagues, we published 4 patients in 2005. All those patients were younger than 10 years old, so we didn't make the link with delayed puberty. And that was made a year later when 4 more patients were published, and again 4 further patients identified by our group. And by then we also recognized the severe myopia, the severe short-sightedness as a major symptom. In the French-Canadian families, comparable disease was characterized a bit later, and Geneviève Bernard found the genetic basis for H syndrome and that disease. Worldwide, I think that's no longer correct. We know, I think, about 300 patients now, and we had analyzed 105 in depth already 7 years ago in 2014. And those are the 2 publications. So the milestones were the discovery of the first 2 genes, the description of the large cohort in 2014, the discovery of the 3rd gene, which causes actually the minority of 4H leukodystrophy cases, atypical forms without hypomyelination on MRI, because those also exist, description of very severe forms of children with variants in POLR3A, description of an extrapyramidal variant just a short while ago, and more in-depth description of the hormone abnormalities. And you see that Dr. Bernard and I have a really close collaboration and a very pleasant collaboration on 4H leukodystrophy. So what is this hypomyelination I'm talking about? So some of you probably know it, perhaps all of you. I hope you bear with me when I explain it, because I would like to all of us be on the same level. In the first 2 years of life, the brain matures or develops, and that means that the nerve fibers, which you see here, are actually isolated and protected by those myelin sheaths produced by oligodendrocytes. And we can follow that on MRI. You see this MRI of a newborn and this MRI of a 2-year-old child, and you see how different the white matter signal looks like. Here it is light gray, and here it's dark gray, almost black. And that's all the myelin which has been made during those 2 years. And the oligodendrocytes are actually producing the myelin sheath driven by signals from those axons. And oligodendrocytes are cells with a lot of tentacles. And at the end of those tentacles, they have those huge flat sheets or pancakes which wrap around the axon many, many layers to protect it and also to provide nutrients to the axon. So it's a very important part of the brain. And I think it's totally understandable that without myelin, things are not working properly. And this is a process which is very tightly regulated and also quite fast. Oligodendrocyte actually makes those myelin sheath, which means more than 6,000-fold increase in surface area within a couple of hours. So that's a huge actually exercise for a cell. And I think it's the only time in the human body something like this happens. And in hypomyelination, that process doesn't happen properly. You have a severe deficit in myelin, and an MRI of a child with hypomyelination, that's a 6-year-old child, actually looks very much like the MRI of a neonate. And that's what we call hypomyelination. And 4H leukodystrophy is one of the most frequent leukodystrophies with hypomyelination. You might have heard of Pelletier-Merzbacher disease. That's another relatively frequent hypomyelinating leukodystrophies. Okay. Oops. The other abnormality many patients with 4H syndrome have is a shrinkage of the cerebellum. That's a part of the brain which controls coordination and motor learning. And you see this in a normal, in a healthy patient, in a healthy control, and in a patient with 4H leukodystrophy, where the cerebellum a bit looks like a tree without leaves. So you only see the branches, but not the full leaves. So this is the other important finding. And then the MRI of a child or adult with 4H leukodystrophy has some little clues, which often allows us to diagnose it when seeing the MRI scan. A little clues which are a little bit different from other hypomyelinating leukodystrophies. And what's a bit, or what actually was astonishing us when the genes for 4H leukodystrophy were found was that those genes encode for proteins which are important for a very central cellular process, which is protein synthesis. And the big question is, why do patients with 4H leukodystrophy have so prominent brain symptoms, have this hypomyelination, when a process is affected which is actually working in more or less every cell? And that's a question we haven't understood yet. We wonder whether that might have to do with the huge transformation of the oligodendrocytes who have to synthesize all these sheaths. But again, we haven't understood that properly. How frequent is it? The frequency, it's unknown. And many atypical cases and adult cases are still largely underdiagnosed, certainly mild cases. And among hypomyelinating leukodystrophies, it's the most frequent disorder. And this is the Amsterdam hypomyelination cohort several years ago. So those are all hypomyelination patients we had seen at that time in Amsterdam. And you see that the 4H is blue. In Amsterdam, it's the largest diagnosis in hypomyelination, but that's also why we see, because we see so many 4H patients, not only from the Netherlands, but from all over Europe.
I had a question, Dr. Wolf.
Yes, of course.
This is Hillary Dash. I was always just kind of curious, do you think that kids that get diagnosed with cerebral palsy, like, is that, do you think, common that, or is there a chance that they could be misdiagnosed, or like, or is that, I was just wondering if that was like they just assigned that versus going any further.
Yeah. Thank you for your question. I'm not so, I think at the outside it may be the case, but as soon as you have the MRI, you wouldn't make the diagnosis of cerebral palsy, because the MRI clearly shows leukodystrophy and this cerebellar atrophy, pointing to another cause than cerebral palsy.
Okay.
So the 4H you probably all know stand for hypomyelination, hypodontia, and hypogonadotropic hypogonadism. You can have patients with mutations in either of those genes and none of those H's. So that also is possible. Those patients usually have then at least the cerebellar atrophy. Additional frequent symptoms are myopia in 80% of the cases, and usually severe myopia. So patients who have -10, -12, and even higher myopia. Small stature, about half of the patients, and we see a broad spectrum of severity, probably depending on the specific genetic variant, but this is also an open question at the moment. For some mutations, we know quite well what to expect, but for many of them, not very well. And most patients actually do learn to walk without support at a relatively normal age, but there are patients who are much more severely affected, and patients who are have only very, very mild symptoms and are diagnosed, have their first MRI at the age of 45, as I have seen. So that's all possible. So we think that this late onset is seen in about 10% of the patients, but I'm not so sure whether that's true, because as I said, those really mild forms may be underdiagnosed because you wouldn't make an MRI scan. So the important symptoms and signs, the balance problems, we call ataxia, tremor of the hands, language problems. Many children actually exchange letters when they talk, mild learning difficulties or intellectual disability. Some children have clearly autistic features. Epilepsy is rare actually in 4H leukodystrophy. The teeth, I think you have more experience than I have. You see all kinds of tooth abnormalities. Teeth at birth in about 20%, late dentition, atypical order of dentition, because usually those lower incisors should erupt first and then the upper incisors should erupt. Abnormal tooth form and color, prone to cavities, and lacking teeth or hypodontia. And some patients need surgical excision of deciduous teeth to allow the permanent teeth to come.
I have a question.
Yes.
On a dental question, actually. My son Matthew, he has pretty much his full set of teeth, but they did come in an unusual order. That was one of the first things that Dr. van der Knap had asked us in 2008. And he always had wide gaps between his teeth, and now he's fully disabled. He's pretty much in bed most days, does not move. But I'm finding that the upper teeth they've closed, like there are no gaps. They're closed. His upper jaw has kind of coming in on itself. Is that something common or something I should be concerned about?
No, you shouldn't be too concerned about it. Our jaws actually develop because we use it. And if you don't use it so much for chewing, the jaw doesn't grow so much. So even with fewer teeth, you can have when you grow up, less gaps in between.
Okay, that was just something I was starting to notice in the last few months, and it was a concern, and he hasn't been to a dentist with COVID. So
yeah, of course. Yeah.
Thank you.
So otherwise, we have sometimes growth hormone deficiency. If treatment is not very successful, abnormal puberty develop in about 75%. A few patients have, as young children, osteopetrosis or increased bone density, which is actually something I think personally has to do with the abnormal tooth development, the abnormal order of dentition. But I just would like to stress tooth and puberty development can be normal. And the clinical course, unfortunately, the disease is not so stable as it looks like in the first decade. The learning problems get more pronounced as children grow older, and most patients slowly deteriorate from the age of 10 or 15 years. The gait, so they often lose the ability to walk without support, the speech, the swallowing, everything deteriorates very slowly, but it does deteriorate. Many adolescents need a wheelchair, and I think we all know patients who really go on deteriorating and have problems with the sputum evacuation, pneumonia, and so on. So other patients are surprisingly stable and don't develop those problems. And I have seen them now for 10, 15 years. They are 28, 30 and completely stable.
I have a question.
Yes, of course.
So my nephew was just diagnosed this past Tuesday with it, and he's 3.5. And I don't know if it's case by case, but is he going to show more progression before he starts showing regression, or is that just based on his case?
I don't know the details of your nephew, but what we usually see in our patients is that they do develop in the first decade. And then they have a stable phase, and then they start to slowly deteriorate.
Okay.
Some of them are prone to deteriorations after infections, like chickenpox or other infections, and can really lose a quite significant amount of skills after an infection, and then slowly regain part of it. But in many patients, it's a very, very slow decline.
Okay, thank you very much.
I have a question.
Yes, please.
Can we get the baby vaccinated to avoid the chickenpox and all?
Actually, yeah, we do recommend the vaccinations. I also recommend the chickenpox vaccination. I think I have seen more patients who had no problems with chickenpox, fortunately, than patients who did have problems. But I mean, it's an easy thing to do. It's easily available. So in many countries, it's part of the recommended vaccinations anyway, not in the Netherlands, but in Germany, for example, it is probably in the US as well. So yes.
Excuse me, doctor, I just missed it. Did you say that our children that are suffering from the 4-H, that you recommend them getting the COVID vaccination?
The COVID vaccination, that's the next point. The question was about the other vaccinations, but the COVID vaccinations, I mean, at the moment, I don't think, at least where I live, the vaccinations are not available for children under age of 16 years. From the age of 16 years, vaccinations are available, and we recommend all our leukodystrophy patients to get the COVID vaccine. We haven't seen, fortunately, severe COVID infections in our leukodystrophy patients, also with other leukodystrophies. We had 1 or 2 patients admitted to the hospital for a bit of oxygen, but not too severe. But still, they are at a higher risk. I mean, they can have a severe disease even with a common cold. Also with COVID, you can have problems even if you don't have the severe adult forms. You can have problems with sputum evacuation and so on. We do recommend the COVID vaccine.
And excuse me, I have a question in relation to that, to the vaccine. In our case, Vicky is 32 years old, so she can be on the list to get vaccinated. But here in Argentina, we only have the Sputnik, the Russian, and one of the Chinese vaccines. Are those also recommended?
Well, that's a difficult question because I think well, in Europe they are not, they don't have a registration yet because our regulatory body, the European Medical Agency, doesn't have enough information to judge about efficacy and safety. So I can't comment. I would personally say I'm quite sure it's better than nothing, but that's the only thing I can say.
Thank you, thank you. That's what we heard, that anything is better than nothing. So.
If it is helpful to anyone, Matthew here is 25, and we did take him. He got the Moderna vaccination, and I tracked his all of his stats, his pulse, his oxygen, his temperature for 24 hours, 36 hours afterward, and he really had almost no reaction. Little tiny bit of a fever, a dose of Tylenol took it away, and that was it. Really no complication at all, if that helps anyone, at least in the United States.
Yeah. Thank you. That's important information. Some of my patients, my adult patients, have also been vaccinated in the meantime, and usually with Pfizer vaccine, some of them with AstraZeneca, and I haven't heard problems either.
My daughter was given the Moderna twice. First time, she got really tired. She threw up in the middle of the night and was fine about a day or two later. With the second one, she got the chills, was tired. She didn't throw up, and I'm assuming because of leukodystrophy, it took her about 2 days to kind of come back. And she had a headache. She had headaches, but no fever.
No. Well, I had the Johnson & Johnson vaccine, and I had also quite tired and headachy day afterwards. I think you probably have had, some of you had the vaccines yourself, so some reactions are possible also in otherwise healthy people. Yeah. So what do we do in Amsterdam currently? We do clinical research on biomarkers, blood biomarkers to correlate with disease severity, and that's actually quite tough. MRI myelin quantification and other MRI biomarkers on the 4H patients. We have now a small research project on epilepsy in 4H, and that's quite interesting. As I had mentioned, it's not frequent, and interestingly, it seems to be more frequent in the patients who don't have the hypomyelination. And I wonder what I have to learn from it. So that's a small question we are trying to answer. And we do clinical research on atypical forms and collect actually data on patients in the long run. And then we have a small translational research group with Fifi Heine and Stephanie Doves, who are both stem cell biologists, and we are working on cerebellar organoids. So we grow little parts of the brain, the cerebellum, in Petri dishes, and those come from patient fibroblasts which were transformed to induced pluripotent stem cells, iPSCs. And we also have set up myelinating co-cultures of those patient-derived cells, and studying the interplay between the axon, so the nerve fiber, and the myelin sheath. So that's actually something to look forward to the results. It's not so easy to set up those myelinating co-cultures, but Fifi and Stephanie managed it, and we are awaiting results in the next month. So that's really exciting. Together with Geneviève Bernard, we have recently looked more in depth at the endocrinological problems, and I've understood that there are also questions around that for you from your part. Thyroid involvement is rare and easy to treat. Growth hormone deficiency is possible, but maybe partial, and treatment isn't working so well. And the question we also have is when to treat delayed puberty development. And that's a very individual decision because it also depends on how severe is a neurological impairment at that stage. Treatment can lead to behavioral changes. I think you all know that adolescents in puberty are not only growing in body and developing all those bodily changes, but also have behavioral changes. And that can be quite challenging, certainly in a teenager or a young adult who also has some cognitive issues. But it's important for bone health. Puberty and sex hormones, testosterone or estrogens. So certainly in ambulating patients, we are inclined to induce puberty. There is also subclinical endocrinological involvement possible. Patients, girls can have breast development, but no or very rare menstruations. Very few patients actually came with the infertility treatment and were diagnosed thereafter with 4H syndrome with only very mild symptoms. And the puberty development can be very, very slow. And boys can have almost no beard growth even at the age of 25 years. So this is something which is more subtle than the full-blown picture of not happening puberty. And this is also something we definitely need more information on. And then Christina already mentioned the data collection or disease registries. And this is really very important and something I think we all have to work together, doctors from all over the world and families, patients. So ultra rare diseases are really rare. You have seen it because probably a lot of the doctors you are dealing with have never heard about 4H leukodystrophy. Atypical forms of rare diseases are even rarer. And information about the natural history, as we call it, or the normal disease course is essential for counseling of parents and families, so what to expect, evaluating effects of future treatments. Usually you treat, if you test a treatment, you use a placebo group, but with those rare diseases, the patient numbers are so small that you often don't manage a placebo group, and sometimes you don't want to have a placebo group because the diseases are so severe. So what we often use for those trials is what we call a historical control group. So information from patients before and compare that to treated patients. This means that the data we collect have to be very good. and you have to think very carefully of what you collect. Understanding basic disease mechanisms, the late deterioration, which is common to many hypomyelinating disorders, not only 4H leukodystrophy, but also, for example, Pelizaeus-Merzbacher disease. And collecting data also helps to understand this kind of disease mechanisms. How to gather this information, disease registries, it's almost not possible otherwise. And in the future, when we do have treatment options, registries are also important to quickly identify possible clinical trial candidates. So if I want to know where are patients with mutations in POLR1C who are still able to walk without support, for example, I need a register who gives me exactly that information. And that makes it not easy, a registry, because you have to think very carefully of how to build registries, how to collect information, with what system, but what information to collect is at least as important. And we just did that for another leukodystrophy, which is a bit more frequent than 4H, metachromatic leukodystrophy. Some of you probably have heard about it already. And we actually decided on what information to collect with the Delphi procedure. That's kind of a you collect information through questions, through a survey, with the international group of experts who have all experience with MLD, and also a cooperation with industry and regulatory bodies, as the European Medical Agency or the Dutch Disease Institute. So this is actually very important for a registry, and I think that's also understandable. You want to build a registry for the following the FAIR principles, and this is findable. So you can find the information you need, accessible for not only me or Dr. Bernard, but also other doctors and families and patients and patient associations, interoperable. So you can actually, if you want to merge two registries, it's easy to do and reusable. You should be able to reuse the data for another trial or another project, not only for one specific question. Patients, there are different stakeholders for registries, and patients, of course, want to get better, and we also want to make patients better and provide good care. Also, your questions about the vaccinations, for example, is important, as deterioration with infections and fever has been described in 4H leukodystrophy. For researchers who want to understand the disease, you need to ask other things. Pharma industry would like to bring a treatment to the market. They often have also financial gains in mind when working with disease registries. And for some of the rare disorders, there are even several registries separate, set up by different pharmaceutical companies. So for the one medication A, there is one registry, and medication B, another. You don't collect the same data, so you can't compare treatments. And that's actually quite a setback if you would like to compare treatments. And governments would like to have safe, efficient, but also affordable treatments. And for all this, you need good registries. So setting up a good one, and also have the collaboration of you, the families, is essential. So thank you a lot for over the years sending clinical information, photos and videos of your children or yourself. and also physicians in the whole world for sending patient information, MRIs, blood, skin biopsies, and so on. And I would also like to thank all of the people who do hard work on 4H syndrome, especially Geneviève Bernard, Adeline van der Ver in the US and Canada, and Mariana Bujani, our neuropathologist, and Fifi Heine, the stem cell biologist, and Resi Verwenne, our geneticist, who does all the genetic diagnosis for 4H. And of course, Mario van der Knaap, who's the head of our center. So please ask your questions.
Dr. Wolf, thank you, first of all, for the amazing presentation and for joining us for this call. I had a question about the trials that you mentioned. Mm-hmm. In your lab, you mentioned 2 trials. Could you share a bit more about them? What leukodystrophies are they in, and what modalities you're using to target, and just share a bit about the trials?
Yeah, of course.
Thanks.
One of the trials is, so those are the trials we actually set up ourselves, so without a pharma industry. One of them will start soon. Both of them were delayed by COVID, as you can imagine. One of them will start soon. It's for vanishing white matter disease, and it will be testing a small compound, guanabens, which is a very, very old anti-hypertensive drug. So it was used to treat elevated blood pressure many years ago. And the other disease we are starting a treatment hopefully in the autumn is Pelletier-Merzbacher disease, where we start a small trial for looking at deferiprone, which is an iron chelating medication. Yeah.
Thank you.
And both trials are relatively small, so we won't be able to see very subtle effects in small trials. In small trials, you see clear effects. So, I mean, if you treat a patient with pneumonia with an antibiotic, you don't need to treat 1,000 patients to see whether it works or not. But if the medication works a little bit, that of course also would be interesting, but we won't be able to see that with this setup.
I had a quick question, and I apologize. I was a little late, single mom in this situation. But one thing we're noticing with my daughter as she progresses pretty rapidly is we've had some problems starting with the liver, and she has an atypical form as well. So I didn't know if you had any feedback on that.
Thank you for your question. I have seen liver involvement only in a very, very few patients, and then very mild liver involvement. So subclinical liver involvement actually. So I'm afraid I can't give you a good answer on that.
Dr. Wolf, do you mind explaining a little bit the differences between the A mutation and the B mutation?
Yeah. Yes. In Europe, we see significantly more patients with the B mutation. I think because in Western and Middle European patients, a mild variant is relatively frequent. We see in the patients with the B mutation usually a milder disease course, certainly in the beginning, when patients have a better motor and also better cognitive development. The stable phase is also often longer, but the deterioration is there as well. In the patients with the A variant, they present actually more clearly as the young children with more severe ataxia and tremor. and deteriorate earlier and faster. There are also subtle differences on the MRI. When you look at the MRIs, for example, patients with the A mutation have less cerebellar atrophy, and myopia is also less prominent in patients with the A variant. The atypical forms, like the very severe forms, which are more a basal ganglia disease, so other brain structures are affected more than the myelin. They are usually associated with the A variant.
I have a question with the those kids that have the A variant. Both of my daughters do, and we have seen in my oldest MRIs that she has a lot of basal ganglia deterioration. Is there any specific like things that we should look at, like to be more severe than just typically presenting 4H, or other types of like movements that we need to be aware of with that?
Yeah, the basal ganglia variant is a variant we became aware of only relatively recently, so in the last 2 or 3 years. And it's associated with very specific variants in the A gene, and not the usual 4H variants. We have also in that basal ganglia variant, we have a spectrum of very early onset, we call it a neonatal onset, and a bit later onset, like the infantile onset. That actually is an important difference, because the children with the neonatal onset, so the onset in the first 1 or 2 months of life, are really severely affected. And it's what I would call a different disease. It's I do see some commonalities with 4H leukodystrophy. Some of the children with this basal ganglia variant have, for example, also a hypodontia. But it's different brain structures are affected. The hypomyelination is very, very mild, if present at all. When we collect data, we have to make sure that we collect the right data for this form compared with the classical 4H leukodystrophy. And so also regarding how would you at one stage treat this disease, I think that you would have to do separate clinical trials for the severe basal ganglia, or for the basal ganglia form, than for the typical 4H leukodystrophy.
Okay, thank you.
And perhaps let me mention this. When you do those data collections and disease registries, you have to do the parameters you look for, or you ask, the questions you ask really have to be disease specific. For example, for metachromatic leukodystrophy, we have gallbladder involvement as a frequent manifestation of the disease. So we have to make sure that we ask that. And that's something not important in 4H leukodystrophy, where, for example, questions about myopia or teeth or the endocrinological problems are important to collect. So it's the registries is also something where we have learned as doctors caring for children with rare disorders have learned a lot in the last years.
So I have a question. So my daughter is 16. She's still she's the B mutation. But she is definitely pre-adolescent. At what point, at what age should we start checking into whether we need to have hormone therapy or not? How long do we wait before we try to figure out what's going on there?
Yeah, between 16 and 18 years.
Dr. Wolf, you mentioned work in your lab on atypical forms. Are you working at all? You also mentioned a moment ago the neonatal presentation and kind of extra severe. Are you doing any work focused on that particular?
Yes, actually, when we do our organoids and the myelinating co-cultures, where we culture neurons and oligodendrocytes together, we actually have cell lines from patients also with the atypical forms, because we would really like to compare the differences between the different forms. So definitely, yes.
Thank you.
Dr. Wolf, this is Claudette Collier, and I thank you again for a wonderful presentation and for answering all of our questions. There's so many to ask, so thank you. My question to you is MRIs. So when a child is diagnosed, they have their initial MRI and it's very clear and what's happening. But how often do you suggest MRIs are done as well, you know, along with watching the normal, you know, how are the teeth growing and, you know, how is the ataxia? How are things progressing? What are we seeing? Because I think it's one of those questions that you don't want to put a child through an MRI if you don't have to. However, how important is it that you do that or you don't do that so you don't miss something along the way that could be helpful? So that's one question. And the other is, and I know on our website, we do a lot of back and forth talking about, have you ever seen this or have you ever seen that? You know, and my granddaughter, Addie, my daughter's on the line as well, will be 7 this year. And sometimes she'll get tummy aches and vomit for several days. And you know, they come up with ideas of it could be this, it could be this, you know, but how do we, and maybe that's through some of the registry that we start to put that in there. But these are new symptoms, new things, and they could have nothing to do with leukodystrophy. How do, as you know, a caregiver, a parent, a grandparent, how do we decipher all of this and not panic? Because, you know, the whole thing is about having patience, working with the experts, but not panicking that, okay, what is happening here and why is this happening? And I'm very happy that somebody asked about the endocrinologist, because it's, yes, when do you start to think about that? Because Addie's only 7 years old, you know, she sees enough doctors. I don't want her to have to see more doctors.
Yes, yes,
you know,
completely understand. Well, thank you for your questions. They are not easy questions, and there is also not a black and white answer to it. Let's start with the endocrinology. So puberty between 16 and 18. Thyroid hormones I would do every 2 years approximately, because it's rare in 4H leukodystrophy that you have a thyroid dysfunction, but it's possible. And this is a very easy blood test and a very easy treatment. So it would be a shame if you miss thyroid involvement. For the growth hormone, we don't do formal growth hormone testing in all children who have a short stature or who don't grow, because the growth hormone testing is relatively invasive, and we usually look at a broad indicator of growth hormone deficiency, and in some instances we would do a full growth hormone testing, but not in all. And it depends also on how severely is a child affected. The question of extra symptoms and are they associated with 4H or are they something else? I think it's something doctors and parents alike have big problems to answer those questions. And of course, the children can have something else like migraine or obstipation or allergy, pollen allergy. So you always have to keep in mind that something can be something completely else. And that's important, not always to make the link to the big disease, because a child can have something else and that would need another kind of treatment. So with the episodes of vomiting, it's not something I know specifically from 4H. I have seen that in a lot of leukodystrophy patients, also other than 4H, and also in a lot of patients who don't have leukodystrophy. So I would think, could that be something like cyclic vomiting, and which is a migraine equivalent, and would I need to think in that direction? But you are completely right. To collect this kind of odd symptoms is also idea of a registry, and for that you need to have open questions like, do you have other complaints? And if there is a pattern, if 20% of patients report that, an association becomes more probable. And your question about the MRI, 4H is in many cases a slow disease, not in all, but in many cases a slow disease. In the patients we would do an MRI, and in typical 4H leukodystrophy patients, we would repeat that about every 5 years, also in the adults. And that has several reasons. You would like not to miss something completely unrelated to the disease. You would like to have some comparisons also for the time when we will have treatment options. So you would like to have some historical data for comparison of untreated patients. And you would like, because we know that patients with 4H can deteriorate suddenly, certainly after infections, you would like to have an MRI to compare this with when you have a child who experiences a deterioration, because in that case you would do an MRI, and you would like to have not an MRI from 15 years ago to compare it with. So this is why we do regular MRIs in our patients. In the younger children, we tend to do it a little bit more often. In a child of 2 or 3 years old, we would do the first control MRI after 2 years, and then probably go to a 5-year interval. In the patients with the very severe atypical basal ganglia forms, we always have to keep in mind the respiratory problems and the general anesthesia. So it would be a very individual decision. Usually we would do that at diagnosis, which would be early in the first year of life often. And then we would do it between the second and third birthday to see how myelination has progressed. And then we would actually do a very individual decisions about when to repeat the MRI. If parents ask for a new MRI, we usually would do it. Parents are very different because some parents would like to monitor it very closely, and in that case, we do it.
Thank you so much. That's very helpful, very precise, and I truly appreciate that. And especially about the part two that, you know, something could be non-related to leukodystrophy. I mean, there are things that are passed down, you know, genetically from other things that you have, you know, thyroid or arthritis or you name it. So it must be very difficult for the doctor as well as the parents. So thank you.
And don't forget, your children are not only 4H leukodystrophy patients, they are children and they can have all kinds of other things, but they are also very individual, like all children are. And don't forget that.
Thank you.
Dr. Wolf, your point about the slow progression of the disease and that 5-year frequency on MRIs, just thinking about clinical trials in 4H, are you aware of any work or are you all doing any work on non-MRI biomarkers?
Yes, we are looking at some biomarkers in leukodystrophies in general, also in 4H, and this is neurofilament light. And I don't have conclusive results yet for 4H. For some other leukodystrophies, it seems very helpful. For H, I still can't make out a good pattern, and we hope also to test for other kind of biomarkers, blood and CSF biomarkers in the next years. That would be a nice research project actually to do.
That's great. Thank you.
So we have some ideas about that.
That's great.
Yeah.
Dr. Wolf, I have a question.
Yes, of course.
The last time my daughter had an MRI, she was 10, which is when she was diagnosed. She's 20 now, and she is having a lot of dystonia type episodes and spastic, and we are trying to get a handle of that. It's been going on for at least 6 or 8 months now. Sometimes she's had to be hospitalized just because of having an excessive heart rate. I'm questioning maybe medicines. I'm questioning maybe it's not dystonia. We did an EEG one time and it showed nothing because she had no episodes that weekend. Of course, we were in the hospital. We had no episodes, but they have since come back. We're trying Artane, gabapentin, and Klonopin. Do you have any suggestions of other things to try?
Yeah. Oh, that's also a difficult question. Actually, I have treated some patients with dystonia and 4H syndrome with L-DOPA, with at least some success. But it really depends on the individual patient. Dystonia is always a treatment made to measure. Like also spasticity treatment, you really have to see the patient and in order to recommend the treatment. So that's very difficult. Yeah.
Would it help you if I sent you some videos?
Yes. Yes.
Okay. All right. I'll get in touch with you soon. Thank you.
I also have a question. Just this past week, Josh had an appointment with Dr. Rubin, neurology here at Lurie's in Chicago. We've brought up a point about possible absent seizures. Have you seen any types of, is that like a cause for concern? She said that they may not be absent seizures, but we're still kind of questioning that because he just blanks out and it just stares off, what we call into space. But can those possibly be mild seizures and then be triggered into something bigger? Or is it just something that where he just spaces out because of he's not functioning, or he's just tired, or his body is just giving up or whatnot? What do you think that could be, doctor?
Yeah, thank you. That's you're completely right. It may be a kind of epileptic seizures. It may also be spacing out because the child is tired or daydreaming. So this is both possible. And we have, as I said, some children with 4H leukodystrophy who have epilepsy, not many, but some. So what we would do is an EEG. So to test brain function and see whether there is epileptic activity. Because if those are seizures, we would recommend treating them.
The doctor did that day pull some strings and get him an EEG. We're still waiting for the results on that, but she did pull some strings. I mean, we were there a lot longer than we wanted to be. Obviously, we know how our children are with being patient with things, and they just want to be in their own world. But we're just still waiting for the results of that. But thank you for your feedback on that, doctor.
Thank you. So other questions?
I attended that European leukodystrophy presentation. That was great. I was wondering, I know, I'm sure, I loved the VB Hines presentation. It sounded like, so from what we had there, like they had grown the axons and then they were working through the oligodendrites. I don't know if I can ever say that right, but I was wondering if there was, I know there's probably, it's maybe too soon for any findings, but I was wondering what the kind of progress, or had they grown things, or are we still waiting?
Yes,
or,
yes, the cultures grow nicely, and yes, the only thing is results are taking a lot of time. So I'm also very impatient to see them. So we have a postdoc and a PhD student working on that, Stephanie Doves and Lisa Koch. So they are busy with it more or less full time. Yes, I hope to have results after the summer, nice results after the summer.
Okay, cool. No, that's exciting.
But then it will not be finished, but at least
right.
I hope to have some results.
It'll be the next step at least,
yes.
right? Yeah,
Yes.
okay, cool.
I have a question about similar findings in siblings. My two children have the exact same variants in the POLR3 mutation, and they are 22 months apart. And so my almost 3-year-old is still able to crawl and sit independently. She's never been able to stand or walk independently. And my oldest daughter followed the same kind of patterns, was able to crawl, kind of pull to stand, use a walker, and sit independently. And then right after she turned 3, without any major illnesses, we started to see some decline. And within 4 months, she wasn't able to do anything independently anymore. And within about 6 months, she was totally disabled. And I know that I've talked to Dr. Vanderveer before, and she said that, siblings can be completely polar opposite, and some have very severe symptoms and others not. But do you see that more on a normal basis, or do you see them kind of following same patterns? I know there's not a ton of siblings out there, but we're just starting to get some PTSD since my youngest is nearing the age of 3.
Yes, I couldn't understand it. I feel with you. actually also in those basal ganglia variants, we see quite some differences within a family.
Okay.
So we haven't we haven't understood that either. So there are a lot of things you see that I don't know either, and I haven't understood either. And we wonder whether it's infection or the small genetic variations siblings have, because two siblings have a little bit of genetic variation, obviously. So this is also something we have to work on. Yeah.
Okay.
Excuse me, I have a question. It's about my niece. It's related to what Josh was saying about the absent seizures. Also, my niece has this last year and a half, mainly because of the pandemic and all that. She's been having a lot of these absent seizures, about 30 a day. And they are usually last very, very short time, but nowadays it seems that they might take about 1 minute or a minute and a half, but it's increasing. And actually, I didn't understand very well your answer to Josh in terms of defining whether we have to be sure if it is a case of epilepsy or not, or daydreaming you mentioned. How can you see that with the EEG?
Yeah, in the EEG, if you record such an episode and you see then you see either an epileptic seizure, if it's an epileptic seizure on the EEG or not. So this is, if you record an episode, you can make the diagnosis really 100%. And if you don't record an episode, so if those episodes are much more rare, for example, than 30 times a day, but perhaps 1 time a day or 1 time every 2 days, then of course it's harder to record an episode. And then you have to look at the general pattern of the EEG and whether you see also in between those episodes epileptic activity.
Okay, but it could not be, it could be epileptic activity or not. It could also be something that you call daydreaming or no.
From what you're telling me, that it becomes more and longer, I would think that sounds more like epilepsy than like daydreaming, but still you would have like to do an EEG.
EEG, thank you, great.
I want to, sorry, I don't want to go over and over this, but I do feel like I maybe described my daughter's condition in the wrong way. My daughter is like Courtney's situation with impacted by the basal ganglia. She's on hospice. I know the direction we're heading, and I know that this is rare, but with her starting to show problems with her liver, are you seeing any problems with this variant as they progress with organ failure, or is that more related back to the medications? What are you guys seeing?
Yeah, I'm afraid I still can't answer your question. I would need to see whether what kind of liver abnormalities your daughter has. I have never seen significant liver involvement in my patients, also not in the severe patients with the basal ganglia variant. But that's not to say it doesn't exist, but it's in any case rare.
I have one more question. I have one more question. This is more about the siblings. So my sister, my nephew, I said, was diagnosed last Tuesday. He's 3.5. My sister also has a 6-year-old daughter, and she's pregnant, currently 30 weeks pregnant. I know that they're going to test the baby as soon as the baby is born, but my sister's geneticist told her that she didn't really need to worry about her 6-year-old getting tested. Do you feel that they should test her, because some of it can occur later, correct?
That's also not such an easy question. I don't know the details about your nephew. We wouldn't routinely test older siblings if they are completely asymptomatic.
Okay.
Usually in the Netherlands, it's also not really allowed in an asymptomatic child, but in some cases we do it, but we wouldn't do it standard, no.
Okay, so it would be, they would only do it if it was something like she started developing issue, then they would go ahead. Okay, I just wanted to make sure. All right, thank you.
You're welcome. Other questions?
This is Claudette again. I think just from this conversation today, it just shows how critical it is for us to have the registry and to get as many questions as possible and to be able to share that with the very few experts we have in the field, like you and Dr. Bernard, Dr. Vanderveer, Dr. Knapp. It can't happen soon enough to have the registry and to be able to have all of this information and these questions and these concerns and the details that these moms and dads have that we can just put forth so that you can have that better picture of what's happening out there in the world.
Yeah, I totally agree. Thank you for emphasizing it.
You're welcome.
Yeah, thank you for that, Claudette. And just let's do one last call for questions. I think it sounded like maybe there weren't any more, and I know it's getting late in Amsterdam. So thank you, Dr. Wolf, for staying on, but let's just do one more pause and see if there are any more questions before we wrap up.
This is Sharon Scott, and I have a question. I wasn't able to start right with the group at 1, and is it possible to get a copy of the screenshots that Dr. put up? Because I'm afraid I missed something.
Sure, I can make a PDF and send it to Christina.
Perfect, thank you.
Not tonight, but in the next week.
Okay.
And in the same line, I'm seeing that this is being recorded. Can we get a copy of the recording by mail? Is that possible?
Yes, I apologize. Thank you. I intended to, at the beginning of the hour, to mention that we would record it. There were some families unable to join. So thank you for asking. And yes, it takes longer than you might imagine to download and upload and all of that. But yes, we will share this with the group.
So with that, I just want to wrap up and say a couple of thank yous before we do. First, Dr. Wolf, thank you so much for everything that you do, and especially for making time, late on a Sunday evening to see all of us. This is an opportunity that we all as parents don't get often enough, just because of there are not very many of you and there are more of us, and we're all over the world. And so we so appreciate you taking time to spend with us and to share about your work, which we're really appreciative of, and to answer our questions. So thank you for that and for everything you do.
Thank you for being here.
Thank you so much.
And
Yes.
thanks to the Yaya
Before you go, don't drop. Just a couple more thank yous. Tammy, thank you as always for leading this work. From the calls and all the way back to the Facebook group a decade ago and everything that you've done as a leader in our disease community. Thank you. Julia, I'll come back to you in just a second. Christina and Valerie, thank you guys for everything, all of your amazing work that our family community is so grateful for. And to everyone on the family call, I just, as a dad, you know, when we got diagnosed just a few years ago, it felt so, among other things, lonely. And it's really nice that we can spend this time together.
Yeah.
It's so exciting to see. I mean, Dr. Wolf quoted like 300, and to see that there are 20 families on this call, that's like pretty significant. And it speaks to the community that we create together, and the way that we're there for each other. And it also speaks, I think, to the contribution to research that we're all making, that we all want to be a part of this. Claudette spoke and Dr. Wolf spoke about the importance of data collection, and you'll be hearing more from us about that very soon, because we'll be launching our effort next month. And just as a dad and a member of our community, that's really gratifying and exciting for me. So thanks to all of you. And so I'll just conclude by, like, look, we know more than most people how special milestones and birthdays are. And so one of us is turning 20 tomorrow, which is I wish it was me, but it's Julia. So Julia, have an awesome, happy birthday. Have a great party. I hope.
Can we sing? Can we sing?
Yeah. That's a great idea.
Okay.
One.
Happy birthday to you.
Happy birthday to you. Happy birthday to you.
Happy birthday to you.
Yay!
Have an awesome margarita, Julia, or 2 or 3, and have a fun birthday.
Thank you.
Happy birthday.
Fun.
That's great. Bye, everybody. Thank you.
Bye, everyone.
Thank you.
Bye.
Thank you.
Thank you.
Bye-bye.
Bye, everyone.
Thank you all. Thank you, Dr. Wolf. Bye.
Thank